Telehealth Resource Center, and I would like to welcome you to our June webinar with our friend Jonathan Neufeld. As we're taking a little bit of time waiting for people to join us, let me just take a minute to familiarize you with our Adobe Connect page if you're not familiar with it. I'm showing the green arrow. That cool little thing is showing you the Files pod. You can click on that link and download the uh, presentation for today in a PDF format for your reference. Below the Files link is a web links uh, pod, and that pod will link you to our website, to the Upper Midwest TRC website where Jonathan works, a SurveyMonkey survey asking you what you thought of today's presentation and what you'd like to see in the future, and a link to the page with our mental health toolkit so you can watch the whole thing once you've found out how cool it is. The chat pod down below is intended for everyone's use to ask questions about progress of the webinar, about technical issues you might be having, different kind of mechanical things that are involved with our presentation today. And the Q&A pod down below is where you can ask Jonathan questions. You can type your question into the pod, and it'll show up in his pod and ours, so we can just jump right in and interrupt him if we need to get some answers for you. I'd like to also invite you to join us for our next webinar. We're going to talk about patient-centered medical homes. Paula Block is presenting that. Paula works with the Montana Primary Care Association and has been working with PCMHs for quite a while. So she's going to talk about them and about how telehealth can fit into the PCMH model. And of course, I want to remind you that we're having our 5th annual telemedicine conference, which is this year actually spanning the care continuum, and it'll be March 21 through 24th in Seattle at the Olive 8 Hotel. We had such a good time there last year, we decided to go back. Registration will be available in another several weeks, I think, at the link you see on this page, and conference information will be building as we plan the conference further. Well, that's enough of me. I'm going to now introduce our friend Jonathan. Jonathan Neufeld is a PhD and HSPP, that one I'm not familiar with, but he's the clinical director of the Upper Midwest Telehealth Resource Center, also known as UMTRC. UMTRC is a consortium of telehealth providers spread across Illinois, Indiana, Ohio, and Michigan. Their purpose is to promote and support telehealth programs in their respective states. The consortium is led by the Indiana Rural Health Association, which is a not-for-profit corporation dedicated to improving the health and health care of rural Hoosiers. UMTRC receives funding from the Federal Office for Advancement of Telehealth, which is in Health and Human Services, and they provide technical assistance to telehealth programs across the Upper Midwest region, leveraging the diverse resources of its consortium members to improve access to telehealth care, healthcare, and services to the underserved areas. They are an organization just like NRTRC and almost as good. Oh, wait, I can't say that. Dr. Neufeld provides oversight for UMTRC along with specific consultation in technological and administrative aspects of telehealth and clinical telemental health services. Dr. Neufeld has consulted in a wide range of projects related to rural health and telehealth with many organizations over the last 10 years. Those organizations include the Indiana Rural Health Association, the Richard Lugar Center for Rural Health, and the Indiana State Department of Health. And Jonathan has been a good friend and partner for NRTRC for a lot of years, and he was very helpful in collaborating with putting this toolkit together. So with that, I'm going to mute myself, and Jonathan, take it away.
Thank you very much, Bob. Appreciate it. All right. Well, today is a somewhat interesting, maybe a little change. What we're going to do is just some show and tell to let you all know about this toolkit and that it's available, and hopefully stimulate some use of it. I want to first introduce just a little bit about who I am, and by implication, you can also recognize that this is who Bob and the folks at NRTRC are as well. As Bob said, we're a consortium of telehealth resource centers across the country. We have 12 regional centers and 2 national centers. The ones down in the lower left of this screen, TTAC and the Center for Connected Health Policy, are our national centers focusing on technology and policy, respectively. We're not jealous of each other's regions per se, so you can contact any of us at any time. We actually, and we're happy to share anything that we have. We have a national website that we all share at telehealthresourcecenters.org, and there you can find links to all of the telehealth resource centers and all the materials that we put online. All the resource centers can do things like presentations and trainings, webinars, individual and group consultations, and a variety of other things to help you build and sustain telehealth programs of various sizes. All right, so I want to talk a little bit about the purpose of the Telemental Health Toolkit, why we put it together, and what our thoughts were that got us interested in doing this, and then I'm going to talk a little about the topics we cover, and then show you a couple of examples, and hopefully get you interested in using or at least looking at something like this. I've been doing professional video conferencing for about 10 years now. I am not a video production professional by any means. I'm just a clinical psychologist, but I've been doing video since I was at UC Davis Medical Center, starting back in the 90s. And what I've realized over the years is a couple of things. Number one, there are some pretty basic technical requirements that if you meet them, you look a whole lot better on video. If you're aware of a few certain things, you can do a whole lot better. And the second thing that I've realized as video has become more and more ubiquitous around the net, and so many people now are using video, as it's become, as it's grown in usage, you see more and more examples of bad video. And so, and that's okay. We're not trying to make, certainly not trying to make anyone feel bad about video. We're self-conscious enough when we get on screen. But what we wanted to do, as Bob and I talked, and Doris and some of the other folks at NRTRC, what we realized is that when people came to us, as we're talking about telemedicine, people would come to us and say, we want some training for our clinicians. And they want clinical training. And okay, so I thought, all right, I'll do some clinical training. And as we were working with people and training people, we realized that really there were two things that they wanted. And one of those was technical information about how to do a video call, how to get comfortable on a video call. And the other one was, how do I do what I do as a clinician on video? Are there things I need to know besides the legal and any kind of regulatory implications or reimbursement implications? Are there clinical things? Are there just professional skills things that I need to know to do video, to do what I do as a clinician on video? And so we just thought it would be a good idea to put something like that together, especially recognizing that the technical pieces of presenting a good video picture are just as important as the clinical pieces. So what we did is got together in Billings for a couple of days and put together some brief videos. These are all about 10 minutes or less. I think they range between about 5 minutes and about 10 minutes. But we just broke down the domain that we wanted to cover into a series of short videos, and then with some expert editing by Bob, who made me look about 10 years younger and about 10 points, IQ points smarter. We came up with the set of videos and posted them on the website. They're on the NRTRC website, and you can take a look at them there and see the full videos. One of the things that Well, among the things that we wanted to do, as I said, was introduce just some basic videography, some basic kind of technical things, and to help people optimize the audio and video performance just for whatever video conferencing equipment you had. We weren't going to do a how-to about here's how you operate a Cisco 9300 or a Polycom this or video web this way. We weren't going to get into the specific details. But what we wanted to do was provide generic advice. This is how to make any video picture better. This is how to make the sound in any room better. And so then it wouldn't matter what equipment you were using. If you're aware of a few basic tips, then you can do it better, whatever you're doing. And then I also wanted to do kind of the same thing for mental health, just some basic clinical concepts, basic ideas for clinicians working on video to help them understand how to come across the best way possible as they're working with clients. Really, a lot of this is getting people's anxiety level down, getting them a little more comfortable, and helping people to get confident to jump out there and try some things and expose themselves to the practice. And as you do it, of course, like anything else, you get better at it. And then I also just wanted to throw out some basic discussion of some clinical techniques, just because clinicians ask me from time to time, can I do this over video, or does this technique work, or can I really build clinical rapport with my clients over video, because we're actually not looking at each other right eye to eye, and so how do I do that? Well, all of those things are things that we wanted to cover in this toolkit. So just going back to our outline here, and so now I'm going to talk about the list of topics that we covered in this toolkit. So we broke it down into basic video, or what we call technology. And the technology section has 5 or 6 different videos. And I talk about room layout, talk about lighting and sound, angles and framing, and then continuous testing. Some of these are pretty obvious points, and I'm going to talk about I'm going to give examples of a couple of them in a minute. Some of them are a little more subtle, but they're things that I have found over the years can make a big difference in how I come across. We're really in looking at in becoming more critical, more self-critical, more critical about how we look on video. What we're really trying to do is push ourselves to look better. It's pretty easy to have adequate video. It's pretty easy to to get your message across, to be able to get intelligible audio, and to recognize, for the person to recognize who you are in the video frame. You can be pretty blurry and poorly lit, and still people will recognize you and recognize your voice, and you can do clinical work even in those kinds of conditions. But like a lot of other things, first impressions are a big deal. Overall impressions do make a difference, and even if we're not necessarily trying to impress everybody who sees us, we are trying to look like professionals. We are trying to look like we know what we're doing, that we didn't just open the box and a video package fell out of it and we plugged it in. We're trying to look like yeah, I've been around the block and I know what I'm doing here, because that not only says that we know how to handle technology, but it does, although it shouldn't, it does reflect on our professional skills and our professional credibility. So we need to know what we're doing. We need to look like we know what we're doing. So the basic technology section talks about room layout, lighting, sound, some of the basics of getting a good picture, and then the more subtle things about angles and framing. And I'm going to play a couple of clips about angles and framing here in a minute. I'm not going to play any clips about this, but I have a clip on continuous testing. This is a point that I want to underscore here, because because so often clinicians or hospitals, this primarily happens in hospitals, but also clinics sometimes, the video equipment gets used maybe, say, in an emergency department or at a telestroke unit. This happens all the time, where a piece of equipment doesn't get used every day. It gets used once a week or maybe even less. and your skill set deteriorates when you're not using it. And also, at any given moment, just because of the nature of the internet, because it's not yet regulated like our old hardwired landlines used to be, at any moment the internet might not provide the connectivity that we want. We might have dropouts. We might have other just variations that come up because we're relying on a hospital or other organization's internal intranet for connectivity out to the internet. There's all kinds of factors that can come up. So continuous testing not only keeps our skills sharp, but also makes sure that the connection is working at any time we might need it. So that's why I take the time to make some comments about continuous testing in the video set. After that first section on technology, then I spend a little time, and there are a few, six or seven clips on specific clinical topics. I talk about pre-encounter preparation. What do you do before the client comes on, just to line yourself up, get yourself set up so that you can present a good image when the encounter starts. I talk about various protocols that you need to be aware of. How do you get informed consent if your state is one that requires it? How do you inform the patient of emergency procedures or procedures if the video goes down or if we lose the connection for some reason? What's the role of a site coordinator? This is pretty key for any organization that's a little larger, that's not just an individual clinician doing telehealth online. Any clinic or any multi-provider group is probably going to have a site coordinator, and that role is pretty key in keeping video equipment tested, keeping it in shape, setting up calls so that the clinician can walk in, do what they do, and then go out and do their documentation and move on without having to worry about technical details. I talk a little about video etiquette, which is a growing area of interest because more and more of us are on video, and there are just some basic things that you need to keep in mind when you're on video. I talk about some ways to increase patient engagement, and by patient engagement, what I'm talking about is in the moment, in the session engagement. Patient engagement has become a larger topic in population health management and outcomes improvement in general, so you may have heard of it in that context. But what I'm talking about is how do you make yourself as engaging as possible on video so that the encounter, at least for the first couple of sessions, the encounter goes better than the client expects it to go. There are just a few things that you can do to make that better. And once you're over that hump and the client realizes, oh yeah, this is a video call, but this is working just fine. Once they get to that point, well, then you can just continue on like you would normally as a clinician. And then as I said before, I discuss several clinical techniques that you can do in the context of video, and just talk about some of the issues that can come up, how you can be aware of those and prepare yourself for the kinds of challenges that you might see. So I'm going to go ahead and flip to the site, the Telemental Health Toolkit site, actually, and I'm going to share that screen, and then I'm going to play a couple of clips from that toolkit. So here we go. This first one is talking about technology, and I'm going to talk about angles. I'm going to talk about this concept of camera angles and why camera angles are important. So for the first clip, I'm just going to run a few seconds here. In general, you want the camera to be as close to the top edge of the monitor as possible. The aperture through which it's collecting its light, you want that to be as close as possible to the top edge of the monitor. And the top edge of the monitor should sit at about the level of the top of your head, somewhere between your eyes and the top of your head. That's what gives the most natural angle for me to look into the screen, and for the screen, the camera, to look back at me. And it looks more like a conversation rather than I'm looking up to you, you're looking down to me, or vice versa. Certainly you want to avoid side-to-side kind of things as well, where the camera is looking in from the side while I'm looking at the screen. I'm going to look like I'm facing the wrong direction the whole time during a video call. So keeping the camera as close to the top edge of the screen, and the top edge of the screen as close to the top of my head, between at my forehead level or top of my head level as possible. Those are the two first angles that we want to talk about. Okay, so this is, as you can tell, this is just talking about how to set up your camera so that you get the most natural angles when you're doing live video. I had a group just contact me this past week to talk about this. They said, you know, our clinicians started using video and they don't like it because they can't make eye contact with the patients. And I took a look, you know, and consulted with them a little bit to say, you know, tell me a little bit more. Let's see how this looks. And as it was actually the way they had set up their endpoints, the cameras were quite a bit above the screens. The screens were too high to begin with, and so they ended up looking up at the screen, and then the camera actually looking down on the clinician. And the patient side was, some of them were set up various ways too, some of them too high, too low, to the side. So when the clinician was looking at the patient on the screen, they weren't looking anywhere close to the camera. And of course, this leads to the impression that you're not looking the person in the eye, which can be a little, you know, it's just a little off-putting. So aligning the camera properly is a good way to fix this problem, or to mitigate it at least. It's not going to be perfect, probably, but you can at least mitigate it. There are a couple of other things you can do too, so I'm going to go ahead and continue the video. A second set of angles that we want to think about are how I frame myself within the screen, within my image. I can adjust my camera so that I'm sitting obviously side to side, top, bottom, all around. What I want is basically centered, although being a little off-center is not a problem at all. The more important thing is that the top of my head goes all the way to the top of the screen. I'm not, well, I'll say a little bit about bottom in a second, but I want myself to be up at the top of the screen, because for a couple of reasons. First is there's no information above my head that's worth collecting. The top of my head, the top of my eyes is really where the... Sorry, that's not supposed to happen. Camera so that I'm sitting obviously side to side, top, bottom, all around. What I want is basically centered, although being a little off-center is not a problem at all. The more important thing is that the top of my head goes all the way to the top of the screen. I'm not, well, I'll say a little bit about bottom in a second, but I want myself to be up at the top of the screen, because for a couple of reasons. First is there's no information above my head that's worth collecting. The top of my head or top of my eyes is really where the information stops. There's nothing up there. Second is that a person who I'm having a video conference with is generally going to be looking at my face and my eyes, and their camera relative to my face and eyes is going to be sitting above my face and eyes. And I want them naturally, I want to draw them in naturally to look at my face, and at the same time to have their eyes looking as close to into their camera as possible. Now, obviously, they can have their system set up incorrectly and destroy that image, but I want to at least give them as much of a chance as possible as looking at the top of their screen. I want to bring their eyes up to the top of their screen. It also tends to avoid, you know, looking down. Just having myself from the neck up is not a good interacting image. All right, I'm going to stop there for just a second and point out that that this framing issue is one that people vary on, people differ on, but it does make a little bit of a difference, or it can make a difference, especially in conjunction with having your client or patient, or having the folks on the other side of the video adjust their image appropriately so that your image on their screen is up towards the top. It can help them with looking into their camera or looking more toward their camera. You find this sometimes in video systems or you find an example, a bad example of this in video systems sometimes, where the self-view image, you always have a picture of yourself on the screen, or almost always. And if that self-view image is on the bottom of the screen off to one side, then it's pretty easy to tell when someone's looking at their self-view image to check if their hair is straight, or check if there's stuff in their teeth, or whatever it is they're checking. And because they look down and they look to the side, and it's pretty obvious. So keeping your self-view picture up toward the top of the screen, and actually close to the middle if you can, if you have the ability to adjust its position. Some systems are much more flexible than others at this. That can also help with that situation. And then there's a third thing that I want to say about framing, and so I'm going to cut back to the video now. So I want to talk about the bottom. I'm a clinician, and I talk with my hands a lot. I like to have at least some part of the screen. I like my hands to be on camera, and they don't need to always be on camera. I can obviously put them down in my lap, and then you don't see them. But when I do bring them up to gesture, I want to be able to have them on screen. Now, if I were a newscaster, that probably would be distracting if I was just delivering the news in as quick and efficient a way as possible. But I'm a clinician. I'm trying to build, or I'm a professional. I'm trying to build rapport. I'm trying to communicate key points, key understandings, and I'm trying to have a relationship. And it would be best if I were sitting 3 or 4 feet from you, but I'm not. I'm coming in by video. So I want as much of the information as I'm conveying to you to be captured on screen and transmitted so that you can draw an impression of who I am and what I'm trying to say. So I want my hands on screen. And so that's where the cutoff, the bottom cutoff is. Often I'll be sitting behind the desk, and so I'll frame from the edge of the desk on up so that any gesture I make on top of the desk gets picked up on camera. Okay, so there's my framing discussion, and that's about half of the 5th technical video. So it says a lot more about various types of things you can do with setting up the image on screen. The other videos, as I say, talk about lighting, talk about sound, talk about room layout and walls and what's behind you, and lots of different things. So you can go through that series to get some ideas about how to look better on video from no matter what the purpose is for your video call. So the second set, I want to go on to the second set of videos. The second set deals more specifically with clinical kinds of procedures. And I just want to play 1 or 2 clips from this second video in the second set. So this is part 2 of the Clinical Professional series. And in this one, I want to talk a little bit about I'm going to make some general comments for clinicians about getting comfortable working on video. So the clinical skills that we use in video, working over video, are the same clinical skills that we use in person. This is a key point, the starting point for understanding how to work as a clinician effectively over video. The same things that I do in person are the things that I do in a video conference, with a little bit more awareness of how I look and how I'm filling the frame, and making sure that my audio is clear, that my video looks good. But I have to work a little bit harder at not losing sight of the clinical components of the case and what I'm doing and what I'm trying to communicate. Here's what I mean by that. You can do anything over video that you can do interpersonally. There are lots of different types of techniques, and in the next couple of segments I'll talk about relaxation techniques, I'll talk about group techniques, just a few things about that. But what it boils down to is that I want to be doing the same things as much as possible and not let the video aspect of it throw me off or distract me from what I'm actually doing. So that's a key point that that is important for any clinician to recognize is that when you're doing teleclinical work, whatever that clinical work is, you're doing the same thing. You're doing the same clinical thing that you would be doing in person. The video puts you at a distance, but you're not providing a different service than you would in person. You're providing the same healthcare service. I want to go on to another section in this video that talks about modeling for patients. Second thing is that clients, during that transition period and all through working clinically, clients will benefit from you modeling a high degree of comfort, a high degree of engagement. All of the things that you do well are things that you're training them to do. As they watch you, they will see, oh yeah, we're just talking the way we normally would. Oh yeah, we're doing it over video. You can make comments about, move your camera a little bit to square that up, good. Or if you have the ability to move it, you can say, I'm going to move the camera a bit. Okay, good. That's a better picture. But you certainly don't want to do so much of that it distracts from what you're doing clinically. If a patient, assumes an unusual posture and starts talking about something that's very important to them, you certainly don't want to say, wait, let me move the camera. You don't interrupt the importance of what they're communicating so that the technical stuff can be done. If you can hear them and you can follow along, go with that and leave it at that. And this may sound obvious, but really it will, you'll recognize that the level of communication that you can have is very high, regardless of any weaknesses or drawbacks that the equipment might introduce from time to time. I think this is another thing that tends to worry clinicians, that they're somehow going to need to develop a whole set of equipment management skills in addition to their clinical skills, or that somehow the equipment is going to override what they're doing clinically. And I think it's important to recognize that that of course it can be distracting. The equipment can be distracting, but it is also possible to get to the point where the equipment is just the equipment, the video is just the video, and a lot of what it takes to get there is the clinician becoming comfortable with that and then modeling that for the client. Giving off in your nonverbal language and in the way you talk about the encounter, just letting the client know that it's all fine, it's all good. All right, so we're going to continue with one last clip here. A third thing that you can do is when you do have to talk about the equipment, usually I would try and make that at the beginning of the session or at the end of the session. If you have to make some kind of technical comments, make those just in a matter-of-fact way. Recognize that, yeah, we got to talk about this. I just want to do a little housekeeping here. I want to do this, that, the other, and then move on. You deal with it directly, and then make the change, or if it's not possible, then move on to something else. Of course, the equipment, the technical aspect, is part of the encounter. It's an important factor, but it is not the beginning and end. It is not the determining factor of what we're going to talk about and whether it's going to be effective or not. And to the extent that you recognize that and model that attitude, your clients will come along as well with that. Okay, we can discontinue the sharing now, the screen sharing, and we're back to our regular view here. So that's just a taste of the kinds of things that that I talk about in these videos, and hopefully that raises some interest, piques some interest for you, makes it look like something you might want to take a look at, or if you have clinicians that you work with who have questions about video and want to know how's this going to work, what am I going to do, how am I going to do this, hopefully this can be a tool for you to refer people to have them use, and that it'll be helpful for them to get over that first hump, those initial humps, that come along to get people interested. I think that we're at the point where we can take some questions. I know this is a pretty brief webinar. We're not going to need to fill up the full hour, but I didn't want to just play video over and over and over. So I gave you some snippets, and I think we're at the point now where we can just take some questions. If there are questions, I'd be happy to address them.
Yeah, Jonathan, thanks a lot. Just to remind everybody, there's a question and answer pod in the bottom set of pods in your screen. You're welcome to type a question into there for Jonathan, and as soon as we see them, we'll answer them. I also just want to comment that this is the first time we've done videos, and it really worked out pretty well. We're going from the Vimeo server through Jonathan's server, through our Adobe Connect server, through your server, and still the videos came across pretty well. But when you look at them directly, they're actually fairly well put together, I think. If you have questions, please ask away. I'm not seeing any questions coming up, and we would like to have you take our survey to tell us what you thought of today's webinar and what you would like to see on future webinars. And in order to facilitate that, Martha has put the survey on your screen right now. You're welcome to take it now, but we've got plenty of time for questions if you want to ask anything of Jonathan. I'm not seeing anything come in. So, Jonathan, I want to thank you very much for taking time out of your day to work with us on this and to work with us on the toolkit to begin with. I think it worked out pretty well, and I'm sure that everybody who gets a chance to look at it is going to benefit from it.
Thank you, Bob. It was a lot of fun putting it together.
Amazing, we only took one day to do it, or was that two?
I think we did most of all of one and probably a little bit of another.
Yeah. We have a comment from Brian. I don't know if you're seeing this on your screen, Jonathan. He says it was really helpful, and thank you.
Oh, great.
Well, with that, Jonathan, I think we'll just go ahead and sign off. There's just the one comment, and thanks a lot for taking time with us, and we'll see you in August, I guess.
All right, sounds great.